The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you. Hope everybody's having a great end of the summer. I'm very excited that fall's about here. I love fall. Fall's my favorite time of the year. I thought we would continue with another kind of ventilator strategy podcast for a few reasons. I've had this topic on my agenda for the last few months. And, we just obviously released the Ventilator Management, a pre-hospital perspective. I want to thank everybody for all the pre-orders, and very excited to say that it's actually rated number 1 in critical care on Amazon.com. So that is a complete testament to all of you that are following FlightBridgeED. So I want to say thank you for that. Today what we are going to look at, predominantly strategies involved in BiPAP, so non-invasive positive pressure ventilation. I get a lot of questions regarding BiPAP, and when I do ventilator training at bases or on an individual basis, that seems to be the biggest kind of misunderstanding. A lot of you out there may not feel comfortable placing BiPAP or utilizing BiPAP on the specific ventilator. And obviously the two ventilators I use, or I should say work with the most, are the LTV 1200 and the Revell ventilator. Obviously the LTV 1000 is the same thing. It just doesn't have the internal PEEP. But as far as the BiPAP aspect goes, I really believe that we don't utilize BiPAP enough. And when you're talking about pediatrics in general, and all the literature out there regarding VAP and intubation, regarding longer hospital stays and time on the ventilator and things like that, we really should be using BiPAP a lot more. I've actually discussed this with a few pediatric intensivists, pediatric ICU nurses that actually fly, and BiPAP is utilized a lot in the transport environment in those specialties. So I think they've figured that out. They figured out that BiPAP is much better. It provides an excellent way to recruit alveoli, to increase mean airway pressure. The bigger the amount of mean airway pressure, the more optimal oxygenation that we can achieve. So we're just going to really quickly look at two kind of strategies regarding BiPAP. If you don't know how to use BiPAP on your ventilator, on the LTV 1200 or the Revell, if you can go to our YouTube channel, remember, just go to YouTube and type in FlightBridgeED. I have demonstrated how to put both of those ventilators into BiPAP mode. And all the aircrafts that I actually fly on, we do have pediatric BiPAP masks. But again, I think that a lot of times we forget BiPAP. We immediately go to what we've been taught for years, and that's intubation and placing them on the ventilator. So I kind of want to encourage you to maybe try to look at that. If a patient is maintaining their airway, they are conscious, and they can actually trigger the ventilator in BiPAP mode. I think that's an optimal way to go. The two strategies we're going to look at are hypoxemic respiratory failure and hypercapnic respiratory failure. So basically an oxygenation failure patient versus a ventilation failure patient. We can always start with BiPAP with kind of two standard numbers. So our IPAP, we have to remember, is our overall minute ventilation, and our EPAP is essentially going to be the lower pressure, and that's your oxygenation side. So you can say IPAP is ventilation, EPAP is your oxygenation side. And remember, when we're dealing with a ventilator, that's what we always want to kind of look at. How do we affect oxygenation, and how do we affect ventilation? So IPAP is ventilation, EPAP is oxygenation. And that's why BiPAP, or non-invasive positive pressure ventilation, is so beneficial, because it gives the patient that lower threshold to exhale over. And we know that specifically with our obstructive lung patients, those patients have a real hard time getting that air back out, and they can't exhale properly. So allowing them the ability to exhale over that lower pressure is very, very optimal. So when we look at IPAP and our EPAP, where do we start? Well, there's a great starting number, and that's 10 and 5. So if you start with most patients, where I would say I would start all of my patients with a 10 and 5. So a 10 on my IPAP, a 5 on my EPAP. And if we're dealing with a hypoxemic respiratory failure patient, and you can pretty much look at most patients starting out as that, just say, all right, what do I have? Do I have an oxygenation failure or a ventilation failure? And a lot of patients in the initial stages of our care are going to be kind of a mixed disturbance in regards to oxygenation and ventilation. They're going to probably be hypoxic based on an oxygenation failure if it was a true oxygenation failure, so some type of a shunt, ARDS, pulmonary edema, something like that. In a hypercapnic respiratory failure, so a ventilation failure or an obstructed lung patient, they may be oxygenation deficient or hypoxic because of low minute ventilations or low tidal volumes. If we're not moving enough air, that's going to lead to low minute ventilations and hypoxemia. But I caution you to remember that a ventilation failure patient, even though they may be a little bit hypoxic, if we fix the ventilation side in those patients and we understand what's causing the ventilation failure and we fix that, then the oxygenation side is going to take care of itself. So again, we're going to start, let's just look at a hypoxemic respiratory failure patient. If we start at a 10 and 5, the big teaching point here is if we're going to increase our IPAP or our EPAP, we're going to do that by 2 centimeters of water. And we have to remember, again, our IPAP is our minute ventilation and our EPAP is our oxygenation side. So if your patient is very severely hypoxic, and we start with a 10 and 5, and we identify that maybe a 10 and 5 is not optimal, we're not gaining our oxygenation like we want, our O2 sat isn't increasing like we want, we're going to want to increase our EPAP. So we're going to increase our EPAP from 5 centimeters of water to 10 centimeters of water, but we're also going to increase our IPAP. So the rule is if you increase your EPAP, you're going to increase your IPAP. So you increase them equally. So any change in either one, you're going to change the other one. So for this patient, if I want to change my EPAP, which is my oxygenation side, is going to maintain that higher recruitment during exhalation from 5 to 7 centimeters of water, I'm also going to increase my IPAP from 10 to 12. So if I started out at 10 and 5, I'm going to increase now to 12 and 7. And you're going to continue to do that. If I'm going to increase again, I would go from 12 to 7 to 14 and 9. And you're going to continue to do that. And so any increase or in one is going to cause an increase in the other. But you're going to have to affect that change. So the rule is for any hypoxic respiratory failure, keep the gradient the same and increase both the IPAP and the EPAP equally. All right, so that's the rule. Start at 10 and 5, evaluate your oxygenation status by your O2 sat, and then change your EPAP and your IPAP the same amount by 2 centimeters of water, and then evaluate and keep reassessing your patient to identify if you have a positive change. Now, in contrast, if you have a hypercapnic respiratory failure patient, we start out the same. We're going to start out with a 10 and 5. But remember, the whole strategy here is, again, understanding the ventilation failure, the obstruction aspect. So these patients can't get the air back out, and so they need a gradient that actually gets wider. And so kind of the strategy here is you're going to titrate your IPAP up by 2 centimeters of water because, again, that's your ventilation side, right? So if we start at 10 and 5, we're going to increase our IPAP from 10 to 12, and we're going to also decrease our EPAP from 5 to 3. So the whole rule here is you want to make that gradient larger. All right, so we're going to make that gradient larger. And by making that gradient larger, you're actually optimizing ventilation, you're optimizing the exhalation process, and you're reducing the amount of pressure that they're actually having to exhale over. So again, the rule is we want to improve our ventilation. But we improve our ventilation by increasing our IPAP. We also want to improve the exhalation aspect, so we're going to reduce the EPAP. Because again, remember, even though they may be a little bit hypoxic, and a lot of them have that mixed respiratory hypoxia versus hypercarbia aspect, the oxygenation deficiency is secondary to the ventilation failure. And if we fix that, the oxygenation side is going to take care of itself. So again, we want to look at this, and we want to increase the IPAP and the EPAP gradient. That's our goal. So the gradient between our IPAP and EPAP need to get wider. If you remember from our demonstration on the hypoxemic aspects or oxygenation failure, our gradient got closer together. So again, remember, these are two completely different strategies. We have to look at these completely different. We have to remember that in a ventilation failure patient, your EPAP is not necessarily needed. So we want to lower that down and make it easier for them to exhale, but we also want to increase our IPAP to make it to where we have more ventilation. Remember, IPAP's ventilation, EPAP is oxygenation. So that's all I have for this podcast. I just want to really quickly kind of go over BiPAP. Remember, this is a great way to optimize oxygenation, optimize ventilation, really open those airways up, increase mean airway pressure. And this is excellent for multiple different patients. I mean, anybody that's having any respiratory failures, pulmonary edema, COPD exasperation, asthma exasperation, all of these, I don't think we utilize this enough. And I can really say this in the pediatric population. Anytime when we can not have to intubate a patient and we can optimize our oxygenation and ventilation by using something non-invasive like this, I think we should be looking at that. And I think we should be doing this more. I know I'm guilty of this as well. You just forget that you have those masks. You forget that you have that capability. So, think about those things. Think about things that we have to be patient advocates. I know it's cool to, do our advanced procedures, intubate, put them on the ventilator, but anytime we can reduce any instances of possible infection, ventilator-associated pneumonia, aspiration, anything like that, we should be looking at other ways to do so. Obviously, with BiPAP, you have to have a patient that is maintaining their airway, that's conscious, that's alert, all the same strategies. But again, most of our patients are going to respond very, very favorably to BiPAP. So again, if you haven't ordered your pre-release copy, the sale's going to be going on for another week and a half. I have ordered all of those pre-release copies. They're on their way. Again, thank you so much for all the support and the following, for making this book #1 in critical care on Amazon.com. I'm just blown away by that. Again, always feel free to reach out to me, email me, call me, text me, and I will always answer as quickly as I can. I usually answer within 24 hours. So on behalf of everybody here at FlightBridgeED, I just want to thank you, and we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.